So let me introduce you now to the panel members of our first panel, from an healthy economy to an economy of health. So this session will be moderated by Professor Luís Pina Rebelo, which is a professor at Católica Porto Business School, holding a PhD in economics with a specialization in health economics and management. Together with Luís, we'll have Professor Filipe Fonseca, Dr. Fernando Correia, and also Dr. Tiago Ashiguchi. I hope I pronounce your surname correctly, Tiago, but I think you will let me know just now. So briefly, let me just present you the short CVs of these key individuals. So Professor Filipe Fonseca is a researcher and invited professor in management at the Nova School of Business and Economics. She has led multiple national, international, and health consulting projects. She's also the scientific coordinator of the postgraduate healthcare management program at Nova SBE, with a PhD in management also from Nova, and a visiting PhD student on the University of Oxford. Dr. Fernando is the Chief Medical Officer of SWORD, which is a digital muscular-skeletal care company, where he coordinates the clinical validation and clinical affairs. For those of you who are not paying attention to the news, so SWORD is the latest unicorn startup in Portugal. So my congratulations to Fernando and the team already on this milestone. Fernando holds a master's in medicine from the University of Coimbra, PhD in medicine from the University of Minho, with a specialty in neurology. Finally, and our first keynote speaker will be Tiago, which is an health policy analyst at OECD with a PhD in health management and also a master's in biomedical engineering, with tremendous experience in consultancy, academia, and also international policy making. So good morning to all of you. It's an absolute pleasure to have you. And Tiago, the stage is yours. Good morning.
Good morning, everyone. Thank you, Cook. I hope you can hear me well.
Yes.
I'm getting a message: host disabled participant screen sharing.
Will be enabled in no second.
In the meantime,
please try again.
Yes, it's working. Thank you. So I was saying, thank you very much for the invitation to address. Wrong screen. So thank you for the invitation to address this conference today. As
I will share. I think it's easier.
do you see the main screen?
No, yes, no, it's okay now. You can go.
So, as I was saying, thank you very much for the opportunity to present and for the invitation. In line with what this conference is about, I thought I would do what OECD has the privilege of being able to do, which is take time to think big.
I think we just lost Tiago connection, so let's just hold for a minute. So as Tiago was starting to say, his keynote session, of course, when we are talking about economy and health and giving, is he online? No, not yet. So he'll be talking about the resilience of the health systems, particularly in this changing world that was affected by COVID-19 pandemic. So his presentation will foster and exploit how OECD has also studied the subject, and even though he's here speaking on his behalf and not on behalf of OECD. So let's just wait a second so that he can jump back in. We cannot hear you and not see you, Tiago. No problem. So he will be joining in no second. So I will share with all of you so the abstract of the presentation, and in this case, the COVID pandemic has taken a heavy toll on people, societies, and economies worldwide. We were all alarmingly unprepared to deal with a pandemic of the scale and intensity we have seen over the past year and a half. Ensuring that health systems are ready to face future shocks, remembering that not all threats are known, requires both strengthening and also resilience. So an ability to recover from and also to adapt to unexpected threats of both health systems and also wider connections.
Can you hear me now?
Okay, so he's back. Awesome. I think we can hear you now.
Do you mind sharing my slides, please?
No problem, no problem. So there you go.
Very sorry for that.
No problem. I was just going through your abstract in the meantime.
So if you can put it on full screen, that would be perfect. And as always, it's never goes down without a hitch, these Zoom meetings.
It's normal.
Okay, I'll speed things up in the meantime. So I don't know where I cut off, but So I was saying, I don't know where I cut off, but I was just saying that I work for the OECD, but I'm here in a personal capacity. The views and arguments I'm going to make do not necessarily are in line with what OECD countries and OECD thinks. The next slide, two, actually. So actually, the next slide. So we all know that COVID pandemic has been catastrophic. It's taken a heavy toll on people, societies, and economies worldwide. Yesterday I checked, and there have been a reported almost 5 million deaths worldwide. And we all know these are underestimates because undercountings, because of underreporting, testing. And in reality, it's probably much larger number. It's been estimated 1.7 million just in the OECD 35, with life expectancy down in 22 OECD countries. So the direct health impact has been massive. At the same time that this direct mental impact has taken place, for example, in respect to mental health, at the same time that this is happening, there's also a reduction in health-seeking behavior and screenings. For example, for various reasons, not just, well, in part because people don't want to go to the doctor during a pandemic, but also because doctors are not necessarily receiving patients, especially during the first months of the pandemic. For example, in England, urgent referrals from primary healthcare for people with suspected cancers decreased almost 80% in comparison with levels before COVID-19. Naturally, this lack of screening in the coming years might have problems where it's still a possibility. And hundreds of thousands, if not perhaps millions, are living with long COVID and the associated disability that comes with that. A condition we still understand relatively little about. And this is the indirect impact, but then we consider also on health, but then we can consider also the indirect impact on the economy. And in the context of an economy of health and a healthy economy, this is perhaps a very important point. 22 million jobs in the OECD lost last year, a contraction of 3.5% in GDP in 2020. these numbers are astounding by any measure. Can we go to the next slide, please? One thing to keep in mind, though, is that these effects have not been felt the same way everywhere. And this is the impact has been different across regions, countries, and populations. You see those numbers there for different regions, 1.5 and 1.2 million deaths in Europe.
Well, Tiago may be in an area without much network, so please bear with us while he's dealing with the internet connection. Are you back, Tiago? Yes, yeah. You are. Awesome. Thank you.
Having problems with my Wi-Fi, I had to switch to the mobile network. Sorry, I was saying naturally there are the problems with undercounting, but these differences are just massive in the number of deaths and cases across regions. And even when we look within regions like Europe, there are significant differences in cases per million. Germany has half the cases per million as Portugal. These are just two examples. You can find others. When you look at OECD, 50 deaths per million in Korea compared to 2,000 in the US. So you can think of this actually as an opportunity to understand why is it that some countries had such low numbers, some regions had such low numbers and others didn't. And I'll get to this towards the end of the presentation. Importantly, there have also been massive differences across populations. The majority of people who died and who were infected were 60 years old or older, and especially at risk were those living in long-term care facilities. At the same time, poor people, those living in deprived areas, most ethnic minorities and immigrants were at higher risk of exposure and death. So, and in fact, there's a lot being said right now about the economic recovery from COVID, but this is actually not being felt by everyone. And there's a risk that COVID will act to compound existing pre-COVID inequalities. Next slide, please. Now the question is, could we have done better than this? Could we have been better prepared? And this, I don't know if you're familiar with this report, but the Global Health Index, Global Health Security Index, has been in the news a lot for the reason that they've scored the US and the United Kingdom highest in their Global Health Security Index. They scored the US 98 out of 100 in detection and reporting, in the UK 92 out of 100 in rapid response. We all know what's happened in the last year and a half, which begs the question, were the signs misinterpreted? Because the signs, when you look at the rest of the report, they seem to have gotten a lot of it correct. They said globally, international preparedness was very weak. And they did point out a few countries like Thailand that seem to be well prepared. So were we misinterpreting the signs? So the next question, naturally, if you're a policymaker and if you're in the thick of it, is what do you do now? I mean, it's been a year and a half. A lot has happened, but perhaps this is a good time as things we start to talk about a post-COVID period to think, what could we have done differently? What didn't go very well? And this is where we start to think big. So next slide, please. So how can we be better prepared next time? I would argue we need to think about health systems differently. So let's go to the next slide. We need new ways of thinking if we are to handle the next global health crisis. And I think perhaps all of you have heard now many, many times about resilient health systems, increasing resilience. What does that mean exactly? And why does it matter? Now, I'm showing you here a framework from the OECD. It's just one of many. I don't think it is naturally the best one. There are others. I don't have problems with using other frameworks. However, all frameworks have something in common, which is the names, the phases, which you see at the bottom of this chart. Plan, absorb, recover, adapt. They all have this similar language. And the characteristics of resilient systems is that they can plan and prepare. This means that they include steps taken by health organizations and related institutions to prepare critical functions for the operation and of a universe of potential threats to avoid and mitigate disruptive events. And this occurs prior to the disruption. So you essentially plan before a shock happens so that when the shock hits, you can better absorb, recover, and adapt. What does absorb mean? It is the capacity of a system organization to deal with the consequences of an acute shock or extended stress without breaking or maintaining a certain degree of function. And this involves minimizing the disruption, minimizing morbidity, mortality, what we have seen that some countries have done better than others. And then you enter the phase of recovery. You try to regain lost function as quickly and effectively as possible. For example, dealing with waiting lists that have piled up while COVID was happening. And this can lead to a new equilibrium. It can lead to a different system. You can go back to how things were. Things were not necessarily great before. In fact, that's why we are here. So maybe this needs to adapt the next stage to a new equilibrium. And next slide. And the important thing is that once we do that, then we start all over again. This is an iterative process. The adapt phase, which I'm going to talk very little about, is really just setting the stage for the planning phase. So next slide. So I would argue that thinking about a system, the resilience of a system doesn't really cut it if we don't think about systems. What do I mean by that? We need to understand that we live in a complex world, a world made of systems that are interacting with each other, changing each other, as well as the links between them. This is a sentence from our former Secretary General in 2019, just months before the pandemic. And I take note specifically of one thing he said. Within mainstream economics, the understanding of why and when interconnectedness may increase stability or instability has remained fragmented. This is a very polite way of saying we haven't really taken into account systems thinking within economics and mainstream economics. And he finished with a cry for action. Let's use it to shape a brighter future for our economy, societies, and citizens. It's unfortunate that just a few months later, we would have been very well served by systems thinking and a systems approach, and that was unfortunately not in place. I would also argue, next slide, that systems thinking is not enough. We also need to move a little bit away from a sole focus on efficiency, which has dominated policy, economic policy, but also policy in healthcare systems, because highly efficient systems are prone to catastrophic failure. When you combine highly efficient systems with complex systems, you get the potential for cascading effects and for negative reinforcing loops that when something collapses, something else collapses, and so on and so forth. This is where resilience comes in. And it might make the system less efficient in the sense that you spend more on things that you don't necessarily need right now, but you do recover better from systemic disruptions. And this right now, in the last year and a half, seems like something we would have loved to have had. Now, next slide. How do we think about what we could have done better and what we didn't perhaps do very well based on this framework, and thinking with the backdrop of efficiency, combining efficiency with resilience, and thinking about the system as a system of systems. Now, the first thing is the planning stage. Here, you can think about risk factors. Only 3% of total health spending goes towards prevention. And the prevalence of risk factors like obesity, for example, has been associated with COVID-19 deaths. There's been a shortage of health workers that was pre-pandemic that has been made worse by the pandemic. And such capacity was effective at adding capacity by tapping into health reserves, but not everywhere and not always well. Next slide. Another aspect that you see that had potentially drastic consequences was the availability of information and the ability to share that information across silos and to make decisions in real time or near real time based on that information. You see this in Korea, in Hong Kong, in Taiwan. Naturally, all these countries were affected by the Middle Eastern respiratory syndrome. So it's not by chance that they were prepared for it. And maybe if the crisis was different, maybe they wouldn't have been as prepared. But the reality is that before COVID-19, only 4 OECD countries had this capacity of having key national health data available for analysis in real time or near real time. This number has gone up, and it's not publicly available, but it will be soon that a larger number of countries now have this capability, which also begs the question, why didn't they have it before? The reality is that we need more investments in most of what I'm saying requires resources. This means strengthening health systems. Primary care is important in many respects. Universal health coverage, of course, you can argue that in majority of OECD countries, this is the fact already, but not necessarily, and there are still barriers to access. And of course, public health prevention, epidemiological control. Let's go to the next slide, please. And this is where the complex systems angle comes in. We've seen very well, and we're still seeing in parts of OECD and the rest of the world, the impact of global supply chains on the delivery of key products, not only in health. We're seeing now in the UK with fuel and other commodities, but in health, we saw this in the beginning of the crisis with personal protective equipment and with ventilators. And in fact, ventilators are a good anecdote, because in the beginning of the crisis, there was a need for ventilators. A lot were produced, and suddenly we have more ventilators than we know what to do with. So naturally, you don't want to be making these decisions like this. You want to plan ahead and be prepared and combine efficiency with resilience, with redundancy. There are also weaknesses in global public goods, and this is perhaps more related to the topic of this conference, how global public goods are supported and incentivized. Current payment models are actually better suited for short run, let's say efficiency, rather than future prices. And this needs to change. One example is antimicrobial resistance and how antibiotics and antibiotic development is funded at the moment. Next one, please. So let's move on to absorb and recover now. This is really containment and mitigation strategies. We've all experienced this firsthand in the last year and a half. These are naturally context specific, and they will depend on the exact health crisis we are facing, but they are likely to involve the classic public health measures that we've seen in place and the non-pharmaceutical interventions that we've seen, meaning closure of businesses, schools, limitations to mobility. But to do this, and to do this for a very long periods, you can see this in New Zealand and Australia, you need to have trust in government, you need to trust scientists and expert opinion, you need to communicate with the public in a way that not only builds that trust, but also makes them see that there's a value to seeing these interventions through. And then, of course, the question of enforcement, to enforce these containment and mitigation policies through carrots or sticks, or a combination. These are all questions that we actually are still trying to understand. In fact, most of what I'm saying, we're still trying to understand. There are a few key issues where investing in prevention, that's a no-brainer. But of course, you can still go into the details of what to invest in. Next slide, please. We need to support the health workforce. I've already mentioned this, but it can't be said enough. We need to support integrated care. There have been a lot of relationships between hospitals, primary care, and long-term care that have been key in this context of COVID-19 that we have not, we started addressing pre-COVID, but we didn't get far enough. And again, this is a problem of investment, but also the urgency. There have been a lot of mathematical modeling used during the pandemic, and this is great. And we can learn more from predicting and preparing for research, for example, at hospital level, but also at the system level, at the health system. and taking into account the connections to the wider non-health systems, which is key, namely supply chains, but not only. For example, mental health due to people being at home, losing their jobs. These are important things. Next slide. And of course, there have been increases in waiting times because many non-urgent elective surgery like cancer care were postponed because people either didn't go or services were not available. These need to be addressed. I've read that Switzerland has 30,000 surgeries waiting to be performed, and these need to be performed somehow. So in the stage of absorbing and recovering, especially recovering, we now need to address this backlog. And I mentioned this already, tracking the impact of the crisis on the population mental health. This means really like measuring it, which is already complicated, but we need to be doing this and need to be doing it more systematically. And once we measure it, then we can adapt the systems to address the changing needs. Next slide. And finally, of course, you can't talk about COVID without talking about long-term care. The reality is that long-term care, we already knew that it wasn't working well. COVID has shown that it's definitely a broken system. Infection prevention control has been dismal. The workers in long-term care are not valued enough. They are not, we go for cheap rather than investing in trainers, in workers, training them, retaining them. And of course, people with cognitive impairments have been hard hit by this crisis. They've been isolated, and we can't address a crisis if we don't watch out for the vulnerable people who are going to be hit the most. And finally, next slide. What lessons do we take from the last months? How can we start this? So in the adaptation phase, what do we learn, and how can we start planning and preparing for the next crisis? Essentially laying the foundations for absorption and recovery. And this is where I'm going to be a little bit, let's say, I'm going to give you a few hints of what I personally think is important that we look at. So next slide, and next one. So these are just a few, 3 slides on what I think I see as interesting in some of the numbers we see, and there are many numbers we can look at, and we don't have the specific analysis done, but already we can see, for example, in this graph, this is the economic decline in the second quarter of 2020 versus the rate of deaths due to COVID as of August 30 for different countries of the OECD. And what you can see, what I find interesting in this slide is that if you look at South Korea, Finland on the right-hand side, you see a lot of countries there on that corner. So low economic impact, low numbers of deaths. Almost no countries on the top of South Korea and Finland. If you look now to the other extreme, United Kingdom, France, and Italy, you see that are countries with big economic impact, high rate of deaths. Again, you see very few countries at the bottom with high economic impact and low number of deaths. In the middle, it's a mixed picture. But what I find interesting here is that for a long time, it was kind of the argument was that, we can't stop the world, we can't stop the economy. People are going to die from COVID the same way they're going to die from other diseases, and the economy is to keep going. But what this shows is that that's not necessarily the case. We have a very strong indication from this graph that there is not this trade-off, that if you have a low number of deaths from COVID because you've instituted strong mitigation, then you're going to have a large economic decline. That's not necessarily the case. Next slide. And this relates to the Synergy index, as I was saying, so how strong the policies you put in place are. Here I want to illustrate where South Korea is. So you see is somewhere there in the middle. The United States and France have much higher stringency indices. And what this shows again is that it's not necessarily that you have to be very stringent to have lower numbers of cases and deaths. And and also impacts on GDP. So what's going on here? How can you explain this? Why did France get it so wrong? And did they get it so wrong? Next slide. Next slide, please. Oh, sorry. Go back. My computer is not. Okay. Yes. What worked best? So I think this is the first clue at what's going on here. There are countries that went for elimination. Basically, they went for 0 COVID cases. The idea behind this is that 0 COVID cases means 0 deaths, 0 hospitalizations, etc., etc. So if you nip the problem in the bud, you don't have all these subsequent problems. This is a good example of a systems thinking approach. There are countries that went for mitigation, and you can see here, this is a paper from the Lancet showing that elimination created the best outcomes for health, the economy, and civil liberties. It's very, let's say, speculative, but this shows you perhaps the start of an analysis. Now, next slide. So essentially, where do we go next? As I said, these are very early days in terms of an analytical work. We do have all this previous work to build on in terms of good practices, things that probably should have been done before the crisis. Now we need to do the hard work of putting it all together and thinking it through in terms of what constitutes a resilient health system and how do we get there. And this is an ongoing project that the OECD will produce results in the next year. It is a horizontal activity, meaning a whole of government approach at the OECD. There are some common elements already that we see as important. One is ensuring that our redundancies, this is again combining efficiency with resilience. Second is to design systems that have properties that allow recovery and adaptation, and using stress tests to see if they're working as intended. And finally, to develop methods for measurement. And this requires a consistent framework for measuring resilience and a framework that is predictive, something that we struggled with before the pandemic in the Global Health Security Index. Next slide. So thank you very much. I'm so sorry for this chaotic presentation and for taking so much time out of the panel discussion, but thank you for bearing with me. Looking forward to the discussion.
Thank you, Tiago. I welcome now Professor Philippe, Professor Luis, and also Dr. Fernando to turn on their cameras and start the discussion. Good morning to you all. Thank you.
Good morning to all. Thank you very much, Hugo. Thank you very much, Tiago, for the presentation, which brought to light undoubtedly some very interesting analysis and statistics. I was particularly interested by the way that you opened your presentation, clearly referencing something which I'm always very keen on also passing on this understanding to students and so forth, which is health is in fact, we need to look at the health system as a subsystem of a more general system, namely the production system, the consumption system. I mean, we have health economists looking at health as a commodity, but it is a very particular commodity because we need to enjoy it in order to enjoy all other commodities, to consume all other commodities, and to produce all other commodities. So this might be related to the statistics which Tiago presented clearly on how maybe eliminating COVID might leverage the economy. And it has everything to do with our general title, which is how we need to, how we're transiting from a healthy economy to when we need to think about an economy of health, of the health sector, of the health system, and how it generally will support the more general economic system. It was also very clear, for instance, in our experience in Portugal, how we still need to work in this systemic approach, mainly in terms of understanding our production capacity in the public sector, within the public sector, in the different hospitals, in the private sector, and matching all of that and something which, a pandemic means a threat, but it might also represent an opportunity. And something which I identified as an opportunity was how in the public sector, for instance, doctors used a simple WhatsApp group to mismatch all equipment needs, all equipment surpluses, and basically creating an informal informational system. So we actually got a question here from the public, from the people assisting, that also stated the pandemic meant an opportunity in terms of, it also meant some opportunities in terms of identifying, for instance, the strength that home office might represent. And so I'd like to start this discussion by asking Fernando. Maybe Fernando clearly is at the lead of optimizing resource usage at a distance. My interpretation is that your startup clearly provides, optimizes access to health, working informational systems and working at a distance. You clearly might have doctors in home office, for instance, and so this goes along with a question that was asked. And also, Sword Health clearly represents, in my point of view, an opportunity to reach have a further reach to patients, even at a distance, and better matching of production health specialists and consumption of health. So, Fernando, how do you feel? What is the receptiveness of health practitioners and also on the patient side to this type of approach, for instance?
Well, thank you so much for the invitation, and thank you, Tia, for the keynote lecture. I will answer your question. Just want to frame it in the appropriate context. I think Ken touched a series of very important issues, and prior to the pandemic, there was really no visibility to the need for strong public health policy and sector, and that speaks to how unprepared we were to face a pandemic, but it also speaks to the way we haven't been organizing our healthcare systems around prevention. Second, we've experienced during the pandemic a complete disruption in healthcare delivery, especially because we had COVID, people got serious illness, they went to hospitals, hospitals were clogged. You needed to reavert all resources to dealing with serious illness caused by COVID, which meant surgery stopped, outpatient visits stopped. What we've seen actually is that, and it's interesting that Tiago mentioned high efficiency as an enemy of adaptability. I would say high efficiency in the sense of specialization. So what we've seen is that by and large, we have built healthcare systems who are very good at dealing with acute illnesses. People used to die a lot from acute conditions 30, 40 years ago. They don't do so now, which means that we have a long tail of chronic conditions to deal with. And this has everything to do with the answer I'm going to give and the question that you posed, which is, since it's more about dealing with day-to-day clinical needs of people and chronic conditions, what this means is that we need to shift the focus away from hospitals into primary care. But we also need to provide a way to hospital systems not being clogged with acute patients and being able to respond to that long tail. And this is exactly where digital health and telehealth comes into play. A lot of hospitals suddenly realized that 50, 60, 70% of all outpatient activity could be done via telehealth, because essentially there was no other way to deliver care unless you picked up the phone or found about a Zoom call. And so digital health, and so telehealth was very residual before the pandemic, and now it's all the rage because it's simple. It's a telephone, it's a video call, but it doesn't give you the element of getting information out. It still requires a one-to-one interaction between a physician, a nurse, a PT, and a person. It doesn't have the multiplying effect of technology. And that's where digital health and short health particularly comes in. I would say that the majority of healthcare institutions have now realized that we've been very bad at treating chronic conditions. We've been very bad at doing day-to-day stuff. And the day-to-day stuff can be largely done, I'd say 80% done via telehealth. And that is a complete transformation that I think, I mean, telehealth is here to say. I'll just give you an anecdotal example. We are running clinical trials in the US. We are a digital MSK care provider. We are comparing digital programs against conventional PT. What we are seeing, what we used to see 3 years ago, is that we found that some people were skeptical about digital interventions. So some of them refused to enter the clinical trials because they didn't want to go to the digital group. What we are seeing now is that people don't want to go to face-to-face treatment because they're afraid of catching COVID, and it disrupts their lives completely. Currently, it's just strange that I need to take 3 hours of my life to attend a physician appointment. So I think there is an opportunity here to completely transform the way that we are. And I'm not saying this is a solution for everyone, but I'm saying that roughly 50% of all outpatient clinics, of all outpatient visits could have been done and can be done via telehealth, especially if you take the step further into digital health, combining hardware and the transformative power of technology to not need 30 minutes of a healthcare professional, which is expensive, to provide 30 minutes of care. These are the opportunities that lie ahead and that were opened by the pandemic. So shift towards public health, shift towards primary care, and shift towards tele and digital health.
Very well, Fernando. Thank you very much. I agree. Clearly, we need to shift to a more proximal approach to the patient. Actually, there's an author which is Michael Porter, which has long discussed, a more holistic approach to the health system. Again, rethinking the system, not on the basis, of the episode, the health episode, but thinking on the patient life cycle. So, accompanying the patient from the beginning and acting in a more preventive way, which goes entirely along with what you were mentioning, and starting obviously with primary care. And it's very interesting how I think that proximity might be, leveraged by the digital approach. However, we have a specialist here, which is Filipa, on psychological safety. One of the things which is challenging when implementing change in the health sector, from my experience, is some natural resistance and fears from practitioners regarding responsibility and practitioner responsibility. And so I wonder whether, this is a question for both of you basically, whether this digital approach would emphasize that fear on one hand. So this is a question to Fernando, but maybe before we listen to Fernando, Filipa, would you agree on what I've just said in terms of psychological safety?
Yes, Luis, thank you. And good morning all. And start to congratulate Católica Porto for the invitation. Good morning to all the panel, and congratulations to Tiago for the presentation. Hello, Fernando and Luis Rebelo. Yes, as a researcher in the healthcare services, I think that today's healthcare organizations, in my opinion, need professionals and leaders who respond to the intense pressure that exists in the deliver value, efficiency, results, outcomes, in order to ensure this best care and services. That we have a system of healthcare that is not sometimes focused only in NHS. And as a manager, I think the service sector has been rocked, by COVID pandemic all the time. And I manage lots of projects in particular hospitals, private hospitals and public hospitals. And we saw that these teams in large part from, the inseparable eye contact nature of many services. That is very interesting to see during a pandemic, multiple forms of contacts, customer to customer, customer to employee, employee to employee. And this kind of contact can lead to serious illness or death. So the lyrics of Polish song, Don't Stand So Close to Me, songs all the time when I manage all the projects in the private and public hospitals, of course. So the point is the healthcare system shows lots of fragilities. Luis explained that. So the pandemic is having, in my opinion, a transformative effect on health services. Precisely why? Because many high performance, I think that is the main point, performance by people for people. So the COVID has given service firms no choice but to adapt and transform their offerings in order to make customers and employees feel safe. So this is a big challenge in the healthcare services. In my opinion, the mainstream service topic of trust must now be, a central focus in the service research. So to maintain that trust, and this is important to compare the trust with the fear, to maintain that trust, so organizations, must learn how to more authentically inform and educate patients. And this is a big challenge post-COVID, I think. So we have here with information safety, so leading remote service workers, a better understanding service separately. So I think these new realities illustrate how COVID is opening broad pathways for service and operations management research. That is a challenge. And I'd love to know that Tiago explained lots of things about resilience. And when we talk about this psychological safety thing, it's important to compare this with resilience. So we need resilience more than ever, I think. With so much on your mind, so many tasks on your plate, we want to put, responses to crisis within your control. And I think that we have here lots of things related with resilience. For example, stability, connection, and also this agility. So when we talk about this agility, we could relate this with the resilient systems that are engaged with also a culture of learning. And this culture of learning is related with this psychological safety. And then when we talk about psychological safety, we have here 4 main zones. That is the learning zone, the comfort zone, the apathy zone, and the anxiety zone. And we learn to improve these 4 main zones in the psychological safety thing. And that's
very interesting, Filipa. And you mentioned education and how education that speaks at heart to me, because I definitely think that, and I've had some research on the topic, that education policy is much more linked to health policy. and health consequences than people think. Again, thinking of a subsystem of a more general and larger system. And education has an important part in preventive medicine. Educating the population definitely has an important part in preventive medicine. I wonder, Fernando, I asked a question earlier, which I'd like to revisit, but would it, in terms of psychological safety, do you think education towards practitioners could be, in terms of could help in terms of adopting a more digital approach? And just before, sorry, let me just add, we have quite a couple of questions, curiously, from the people assisting us or viewing us on the carbon footprint, the circular economy issues, how the environment is important towards health, how people where people live, what they eat, what they breathe, and so forth. And they're all, curiously, the questions are all related to whether telemedicine or a more digital approach could actually reduce the carbon footprint. So I'll add that into the subject.
I'll try to touch on all subjects very, very quickly.
maybe too ambitious, but sorry about that, but I'm sure you'll.
When approaching skepticism and safety, I think that there are two sides to it. So we've been traditionally taught as healthcare practitioners that, and us as patients, that every meaningful interaction involves face-to-face care. That's definitely not true. The pandemic has proved that. And there are two sides to it. First, from a healthcare practitioner point of view, can I do my job correctly? And second, how will I form the bond with the person? On the person's side is, will I get good care? And will it be strange to interact with another person who's in charge of my health digitally? And actually, what we've seen is, and that's what we've been ahead of the curve prior to the pandemic. Then the pandemic hit, and all of a sudden there was actually no way other than accepting change. And this forced, I think we leapfrogged like 10 or 20 years in healthcare, potentially, as in terms of opportunity. Education can definitely help on this. Education towards healthcare practitioners is going to be harder, because the only way to convince healthcare is using the scientific method, which is providing data. So back to the beginning of the conversation, Tiago mentioned that most of the countries don't have data. If you don't have data, you can't measure outcomes, you can't convince clinicians. We're lucky at SOAR to have data. Second, there's a ton of research that's now being done, especially on the mental health side, that is beginning to prove that you can actually build as strong a therapeutic alliance, or even stronger therapeutic alliance, digitally between providers and patients. And this is because you can use that to your advantage, because technology allows additional contact points. And also technology can effectively bring us more towards, and this is where circular economy comes in. I know I'm tagging all concepts together, but we've been advertising patient-centered care. Patient-centered care does not exist. The concept in practice of patient-centered care is multidisciplinary consultations, where the patient still goes to the hospital and goes from cabinet to cabinet inside the same building. So it's still the patient going around from doctor to doctor. What this allows is, you can decouple, for the first time in history, you can decouple the delivery of healthcare services from a need to travel to and from healthcare institutions. It has never been possible until now. It has never been adopted. So, and now if we think about, And there's tons of evidence like home monitoring of heart failure patients, patients with chronic obstructive pulmonary disorders. Home monitoring programs can save like 25 to 30% of emergency room episodes and inpatient admissions. So more and more, and now you see home hospital initiatives throughout the country. So I think that this is a perfect opportunity to take away a lot of inefficiency that, yes, increases the carbon footprint, mainly in travels. I don't know about how you can decrease the carbon footprint on another number of aspects. Now, touching on to another aspect, and to wrap up the question about education, what we've seen in Portugal is it's a perfect example of the outcomes. It's not a perfect example of communication, but I mean, if I'm feeling good, I'm not going to engage in prevention initiatives. And vaccines are by nature a prevention initiative. But there's a lot of things we can do to improve communication. And this is where a strong public health sector can be crucial, so that we clarify messages to try and reach more and more people and educate them about the possibility of doing other interventions like telehealth that don't require you to actually go outside of your home, and that are much more efficient actually for the economy. I didn't go deep into any specific subjects, but I believe I touched all the different nuances of the question. Unless you lost me.
No, I think we lost Luis, maybe.
I think so. We lost Luis, but well, so let's. I'll take over. No problem. So just a final thing. I would ask both Tiago, Fernanda, and also you, Professor Filipe, just for 30 seconds takeaway message that we can send to the audience on what do we think will be the future in terms of health and in terms of the relation with economy. Just a really brief comment, I think Professor Filipe first, then Tiago, and also at the end, Fernando.
Thank you, Hugo. I saw a perfect, text or paper that bring us information about healthcare system and how to relate this with healthcare. So the paper explained a little bit, just like lead like a garden. So it's important to have the agility of a resilient team that engineers up its empowerment. So the point is, first of all, break up the soil. So it's important, proactively change the systems, the processes, the relationships, and the behaviors between the teams in healthcare system. Another thing, it's plant seeds in the right place. So explore the unique value of your team members and the mission that you have in your healthcare system and company. Another thing, it's ensure essential nutrients that are available. So ensure your team have capabilities, contests, authority to execute all the tasks in a healthcare system. Remove barriers that block the sunlight. So give the team a clear line, to manage all the things in the awarenesses situations. Another thing, it's water and fertilize on a regular cadence. So you could invest in your team by creating opportunities in building, in training, in coaching, and also in mentoring all the professions in the holistic view. And finally, give the plant time and space to grow. So adopt eyes and hands approach in which you could maintain the situal awareness to provide guidance and mitigate the risks and solve their challenges on the front lines, because frontline workers in healthcare are very important, and we saw this in COVID times. So
very well, very well.
That's it. Lead like a gardener.
Lead like a gardener. Very well. Tiago, please.
Thank you, Hugo. I think I'm going to finish on a positive note. So, of course, you look at my presentation and think, oh, this is all so catastrophic, so negative. But actually, I would flip it and say, it's interesting to see how many of the concepts we need to go forward already existed. I mean, complex systems have been around for ages. Telemedicine's been around for ages. The importance of redundancy has been around for ages, not necessarily in economics, mainstream economics, but in other sectors. A lot of what I've mentioned in the planning and absorbing stage are policies that we've been pushing for in the OECD for quite some time. So I think it's interesting to see that we have a lot of the tools we need, and now, because of COVID, we have the appetite to use them. We have the opportunity to do something, which perhaps in the past, like Fernando mentioned, if you're not sick, you won't maybe care about prevention. It's the same thing here. There's an opportunity now, there's an appetite. People are understanding that if you plan and prepare, you can tackle crisis better. And we have the tools. This is my my parting note. Thank you very much.
Thank you, Tiago. Finally, most also important, Fernando, please.
Yeah, so this pandemic has taught us that healthcare economy is not separate from the economy. So if healthcare fails, all economy crumbles. And sometimes we've been taking healthcare for granted. And this is an opportunity to not take healthcare for granted and to really think about how healthcare is the basis for all the other sectors of the economy. Tiago showed that, Professor Pinheiro also spoke about that. Second, any healthcare is better than none. So it's time we think about access and using the power that technology has to multiply and to facilitate access. The third aspect is it's all there, but let's think about the basis. On the road between acute, chronic, and prevention, we've been very good by and large at treating acute conditions. It's time we treat chronic. It's time we give more emphasis to primary care, and then on the long tail, let's move towards prevention. Those are my 3 notes.
Very well. So on behalf of everyone, I would like to thank you for being with us. Thank you, Fernando, Filipe, and also Tiago. Unfortunately, Professor Luis' connection was not very good, but well, I think we could manage to close on a high note. So thank you for being here.